Okay. Thank you so much for Casey from the Parkinson's Foundation for helping me record this lecture. This is a lecture a little bit about dystonia, which means abnormal muscle contracture, which can result in tremors. So it is a movement disorder lecture, but it's sort of um, just like an observational lecture about things I've observed over the past 6 to 12 months approximately. I wanted to kind of characterize and at least describe everything that I've observed in my practice to be able to help patients uh, be aware of some symptoms that they have that they may not know that they're aware of or not know how to characterize or describe them, and also to help other doctors and clinicians get an idea of how to approach patients with these clinical symptoms in the case that they may be presenting as part of a syndrome that is not officially a diagnosable or named syndrome, hoping to gather more and more clinical data and genetic data to maybe be able to name this so that it would help patients and clinicians provide the best treatment options. Okay, so um, I have to have a disclaimer though. This presentation is just a combination of some evidence-based evaluation and treatment protocols and some of my anecdotal observations, which are not evidence-based. They are not official. These are just my observations. So none of this information is meant to replace any information provided by your actual doctor. And it does I cannot provide any like official medical advice or treatment plans for anyone who's watching this. This is just like what I've observed. So not all of this may apply to you specifically. So you, if you have questions and stuff, they will have to go back to your doctor who is taking care of you. And that's all my disclaimer. All right, so dystonia, this means basically a sustained or intermittent muscle contraction. And this, we don't know what causes dystonia. We basically think it's due to abnormal wiring in the brain. That's how I explain it to patients. There's no test that shows that you're having dystonia. There's no picture that shows why someone has dystonia. So this is a basically clinical diagnosis. So it is results in an abnormal movement or posture, and sometimes that ends up turning into a tremor, because how I explain it is that your part of your brain is sending a message to a specific body part to increase its tone, meaning like make it move or spasm and tense up. But then another part of the brain is trying to compete with that and say, no, don't tense that up, relax it. So they're constantly competing with each other, which ends up looking like a tremor because one part's telling you to move this way, another signal's telling you to move the other way, and that ends up looking like a tremor. And I'm just showing my hand because that's easy, but it can happen in any other body part. So dystonia can cause slow twisting motions, abnormal postures. It can also be fixed, meaning you can be stuck in one position as opposed to continually moving. And it can be either rapid, jerky, or repetitive. So it's a lot of variation to dystonia, basically. So one example is blepharospasm. That is where people's eyes are closing and they're having a signal to close their eyes and they cannot keep their eyes open. Another form is laryngeal dystonia, where part of your vocal cords and the muscles around the throat are too tense and it causes a spastic quality of speech. And then the one we're going to focus a little more on today is dystonic tremor. So there's 3 proposed mechanisms of why people have dystonia. Again, number 1 is just abnormal wiring in the brain, where part of your brain that's supposed to kind of quash and reduce extra movements is not working. So you have a loss of inhibition, and that makes part of your nervous system overactive, which is supposed to be balanced out, but it's not. And so you have extra movements. Abnormal sensory motor integration. So again, sensation, telling your brain what senses it's perceiving, and then translating over into a motor movement or just kind of something along that pathway is a little bit out of balance. Maladaptive plasticity, again, just meaning wiring a little bit off. Your brain is supposed to be able to adapt and change, and sometimes that mechanism and that repair pathway maybe is not working as optimally as possible. Bottom line, probably abnormal wiring in the brain. So this is a video I would like to show because it just kind of shows cervical dystonia. Are you able to see the video of YouTube?
Yes.
Casey? Okay, perfect. So cervical dystonia means it's affecting the head and neck, and it can affect the jaw muscles, the throat muscles. So here we see this person's head and neck wants to turn towards the right side, and a little bit of tilting, it wants to tilt forward, and it moves back and forth because, like I said, the brain is also still trying to subconsciously compensate for the movement by trying to move you into the other direction. So it can end up looking like a tremor, and it can end up looking like multi-directional movement, most of the time wanting to turn towards his right hand side. Then the next part we check is hands. So this is a little bit of tremulousness, tremor in the hand. So it's not a really obvious tremor, it's just kind of a fine tremor. Okay, so that's that. So that's what I'm talking about basically in this video, and I wanted to show a video of it to kind of show you what I'm really talking about. All right, so dystonic tremor then is, it can affect the head and neck or the hands or both, but it can also affect other body parts. So sometimes patients will say, I have an internal sensation of tremor and nobody can see it, but they feel shaky on the inside. Sometimes their legs have that tremulous sensation where they're standing and they just feel like their legs are jello. They feel wobbly. They just don't feel strong. So that's some keywords to listen for. And so who gets dystonic tremor? So this is the part of the lecture where these are some of my observations. So there are known age distributions of the dystonic tremor. What I have observed is that I have patients, usually young women in their 20s and 30s, but I do have some men as well. When they come in for this, it's typically the hand tremor that they're starting to have. When I have patients in their 60s or 70s, they are coming in mostly for the head and neck cervical dystonia, dystonic tremor. But when you ask this group of patients if they have hand tremors, they usually agree. And if they think back, they say, maybe around my 20s and 30s, I started having a shaky hand. I didn't think much of it. I thought it was just because I was nervous or I had too much caffeine, and I never really did much of it because it was not very significant. So my question to myself and for the future generations, and something we may try to answer, is, are these patients who are presenting in their 60s and 70s, did they have the same thing in their 20s and 30s, and that was really the beginning of their dystonia, or is it just two separate groups? The other thing I observe is, a lot of times I have patients who come to me for a question of essential tremor, and they are in their 20s and 30s. And essential tremor is a different form of tremor. That's an action tremor. When you're trying to do something or write or eat or drink, you have a shaky hand. I am starting to question if those patients actually have dystonic tremor. And when I examine them in the office, they frequently have a combination of essential and dystonic tremor. And the way that I try to differentiate, their specific tests that I do in the office. So I can test their handwriting and certain other maneuvers. But I am starting to notice that what would have been called essential tremor can sometimes have a component of dystonic tremor. So it's just an observation. Okay. So what else comes with it? This is the part of the lecture where this is not evidence-based yet. This is what I've observed, and I'm trying to make this lecture so that other doctors have an idea of what to look for, ask about, and then kind of what to do with some of this information. What I observe is patients with the dystonic tremor, whether it's the head and neck and they're in the older age group, or it's the younger age group with the hands tremor. They have a couple of other things that go along with it. So number one, they have some form of an autoimmune condition, whether or not it's officially diagnosed or named, or if they just have vague positive autoimmune markers that never quite added up to a specific diagnosis, or did not meet criteria for a specific diagnosis, or they were never evaluated by a rheumatologist for extra testing to decide if they meet some site of diagnostic criteria for a specific illness. If that patient themselves doesn't always have the autoimmune condition, I've noticed that many of their family members, first degree family members, meaning mom, dad, siblings, or children, will have some autoimmune condition, whether it's lupus, psoriasis, eczema, allergies, dermatitis, colitis. Those are like the common ones that people say that they know that their family members or they have. Also frequently observed in the long COVID patients. So my theory, and some of this is getting to be researched now, long COVID, well, COVID itself is potentially an immune mediated virus. It seems to potentiate an immune response longer than other viruses. So my question again, and what I'm trying to put together is there overlap with this condition and long COVID patients? Is COVID itself a trigger for all of this? What I suspect and what I found is that patients already had some form of all of these issues. And then when they got COVID or when they got the COVID vaccine, they seem to have an exacerbation of all of these issues. Okay, so what else comes with a dystonic tremor? We talked about autoimmune condition. Next is the connective tissue disorder. So connective tissues are hair, skin, nails, blood vessels, the lining of the blood vessel walls. These are all your connective tissues of the body. So I've noticed that these patients tend to endorse something within the connective tissue disease realm. Again, whether or not it's officially diagnosed is variable, because these can be kind of vague symptoms. So Ehlers-Danlos syndrome is the obvious named form of this issue, where you have such bad looseness of your joints that you can frequently have joint dislocations, hypermobile, very, very stretchy joints, tendency to break things more easily than other people. However, Ehlers-Danlos syndrome is a spectrum, and I do believe that the diagnostic criteria recently changed, so it's become a little harder to make the diagnosis because it depends on a family member also having the diagnosis, which is kind of like, if nobody has it yet, how are you going to diagnose it? I don't know. But anyways, I think it's on a spectrum basically. So what these patients can say that they have, or what you can ask about, is, do they have loose joints, sort of a looseness of their skin, looseness of their arms and legs that's not fat, but it's just like a loose, low muscle tone appearance to their arms and legs? Frequently dislocating things like wrists, joints, ankles. Are they somebody who like rolled their ankle and actually broke something? Whereas if another person had maybe rolled their ankle while playing a sport, they wouldn't have actually broken it, but this person actually broke it and needed surgical or orthopedic intervention. Connective tissue is also your hair and your skin. So people frequently say that their skin is very, very dry, drier than everyone else around them. Their hair is very, very dry. Alopecia means reduction of hair growth, so losing hair in specific patches. Eyebrows specifically being lost is in the category of alopecia that may be under the autoimmune category. So questions to ask your patient about specifically. Okay, what else comes with this? So this is the big one, dysautonomia. So your nervous system has two parts. There's the part that you can control, and then there's the part you cannot control. The part you cannot control is the autonomic nervous system. And you can think autonomic means automatic. Automatic meaning you don't have control over it. So things that your body is supposed to do by itself without you controlling it. So starting from head to toe, this involves blood distribution to different body parts depending on what your body is doing and what position your body is in. Secretions of eyes and mouth and the nose. Swallowing, part of swallowing is automatic, part of it is voluntary. So there's a portion of it that's supposed to be automatic. The heart rate, rhythm are all supposed to be automatic based on what the body is doing. Blood vessels, dilation and constriction based on what the body's doing. GI issues, so constipation, diarrhea, gut motility, your body knowing when it's time to urinate, your body knowing when it's time to not urinate. Those are all automatic issues. Sweating is automatic. Satiety, this is a weird one. So your body is supposed to know when you're hungry and tell you, and then when you eat, your body is supposed to know that it's full and supposed to tell you that as well. Okay, so all of these issues are all automatic issues. So when you have problems with these issues, that's when you know or suspect that something is wrong with the automatic nervous system. So the problems occur when you don't have enough secretions. So you get dry skin, dry hair, dry eyes. Dry skin comes from abnormal sweating and the regular like oil secretion that your body is supposed to make. Patients can complain of feeling vaguely lightheaded and dizzy, especially if they are crouching or laying down and they suddenly stand up, and they frequently get lightheaded to the point of passing out, or not to the point of passing out, but they really need to steady themselves and they have to get up slowly. That's part of the automatic nervous system. The condition that's the official way to diagnose this is called POTS, or postural orthostatic tachycardia syndrome. So basically, when you go from lying down to standing up, your blood pressure should change and increase to push more blood upwards against gravity, and your heart rate should increase a little again to push blood upwards. But when you do it too much, or there's a disruption of this normal reflex, meaning your blood pressure actually drops or your heart rate goes up too high, that means there's something with your automatic nervous system that is just not functioning completely normally. And that's a very measurable response with a specific test that I will talk about later. Bowels and bladder. So patients can frequently complain of diarrhea or constipation, or alternating diarrhea constipation that has otherwise never amounted to any specific diagnosis. And they end up getting labeled as IBS, meaning everything else has been checked for, and there was no real cause of why do they have diarrhea or constipation. One thing to keep in mind here is make sure it's not like a medication side effect for patients. If they have diarrhea, make sure they're not on something like metformin or something like that that could be potentially causing that. And if you've ruled out everything else, then we're thinking maybe it's an automatic nervous system issue. The abnormal blood distribution can not only cause the lightheadedness, dizziness, it can also cause what we call Raynaud's phenomenon, where patients will go out in the cold and their blood distribution to the fingers and toes is again disrupted, and it's not quite working normally, to the point of fingers and toes turning white, blue, purple, meaning the blood distribution is just not being regulated. Some patients also complain of feeling heat or cold intolerance. They're way too hot when everyone else isn't, or they're way too cold when everyone else isn't. A frequent thing to commonly is the cause of this, though. Iron deficiency can cause cold intolerance, so that's something that should be checked, and I'll discuss that in my later slides of my approach to this whole syndrome. All right. So what else comes with this? The next category that comes with this is small fiber neuropathy. So small fiber neuropathy is notoriously difficult to characterize and diagnose because it causes vague symptoms that come and go. They're not always the same symptoms for each patient. The patient themselves can say, like, sometimes it's this, sometimes it's that. It never quite adds up to one specific nerve distribution, which makes it hard to test for in the clinical setting. So it's just something to kind of have a high level of suspicion for and ask about. So patients can say that they feel burning, tingling, tickling, feeling too hot or too cold, feeling like their leg is or arm is wet and it's not really wet. And it's a very vague sensation. It comes and goes. When you test them in the visit, you can test their pinprick, and sometimes they'll say, yeah, I can feel it. But if you test again, sometimes they can say, I don't feel it, or it feels different, or it just changes right there in the visit. So it's hard to reproduce repeatedly with testing, which makes it even more difficult to diagnose. So this is also not picked up on a regular nerve test. So a regular nerve test is called an EMG nerve conduction study. That basically involves using a little machine that stimulates the nerves electrically, and then measuring how fast that nerve transmits a response. And then the second part of this is actually stimulating and causing a muscle contraction and measuring that muscle contraction. That's a regular nerve test that measures large nerve fibers. It does not measure these small nerve fibers. They're just too small. So frequently what ends up happening is patients will have these symptoms and we'll get a nerve test and it'll come back as normal, because it is normal, because the large nerve fibers are working normally. But we have to then expand the testing for small nerve tests, small nerve fiber neuropathy. So I will talk about the test for that when I get to my evaluations page. Then patients also tend to have a lower threshold for pain, meaning stimuli that would not be painful for another patient is perceived as painful for this patient. And this is a very vague thing to characterize because pain is subjective. There's no way of saying how to measure pain. It's completely subjective. Yes, we can put a scale on it, but everyone's scale is different. You can never feel what any other person is feeling. It's just subjective. So it's just something to keep in mind when we approach patients with these symptoms, trying to just keep an open mind that everyone's perception of their symptoms is different, and we do our best to try to characterize it. Okay. This also, of course, comes with the side of mood symptoms. I mean, who wouldn't if you're having these symptoms of lightheadedness, dizziness, fatigue, burning, weird little symptoms? And so, yes, if there is a side of anxiety, depression that comes with it, it may be that the brain is already wired towards those and it gets exacerbated with the onset of the rest of these symptoms. Or it may be that the symptoms itself brings on anxiety, depression of not having a diagnosis, not having a treatment, having pain, or having undiagnosed, uncharacterized symptoms. The other part of the mood is fatigue. So, fatigue is a really big common complaint in the neurological world. Fatigue, I'm going to go through more slides later about what I do for this, but part of fatigue can be metabolic, meaning abnormalities in the blood, iron deficiency, other deficiencies that can cause fatigue. Number two cause of fatigue can be that blood distribution dysregulation, because when the brain is not quite getting as much as it's supposed to and other body parts are, or vice versa, it generally kind of saps the body of energy and can create a fatigue. The other part of fatigue is what we call psychomotor slowing. So, psychomotor slowing is basically when you have depression and it physically causes the body to move slower and feel a reduced level of energy. On the other hand, anxiety can cause the opposite of this restlessness of always moving about and not being able to like relax. So, these are some of the things to just keep in mind to ask patients about or try to observe clinically the difference between like tremor or um, like a organic causes of fatigue due to metabolic abnormalities versus the psychomotor aspects of slowing that can also contribute to fatigue. Okay, again, here we go in my other common observations. This is anecdotal. This is what I've observed myself. Patients who fit into this sort of the syndrome that's not named so far, but who seem to agree to most of the symptoms I've already discussed, also tend to agree that they have headaches or migraines. Um, they can be on the autism spectrum, or they have a history of ADD, so attention deficit disorder, or attention deficit hyperactive disorder. And again, not always diagnosed depending on the age group of the patient. So nowadays, school-age children are more thoroughly screened for these type of syndromes and tested, but 50, 60 years ago, that wasn't really a thing. So you have to ask the question like, did you have a hard time paying attention in school? Did you need special help when you were in school to get through your classes? Were you able to graduate from high school, or did you need any type of special educational assistance? Were you somebody who had a very hard time paying attention to a long task and completing a task and frequently getting distracted? So that might give you a clue into this. The other thing that's also strongly observed in this category is a strong atopic history. So atopic means allergies, basically. So people, for some reason, had way more allergies than everybody else for no real specific reason. That could be environmental, food allergies, having whether or not officially diagnosed or not again. So officially diagnosed means they went to an allergist, they had allergy testing, they required allergy shots, or you notice in their chart that they're taking a ton of allergy medications like Claritin and Zyrtec and Montelukast and Singularia. It's like, why do you have so many allergy meds on board? Are you that allergic of a person? So if the answer is yes, they may be in this atopic category. The other unofficial way to kind of ask this is like, are you someone who everything makes you itchy? Like you put on lotion and you're itchy. You put on any type of jewelry and you're itchy. Clothing, things give you a rash. If you scratch your skin, do you get raised welts or marks? The other way to ask this is, do you have bad reactions to medications, like you react more sensitively than other people? Do you get hives for kind of any little thing, and you get hives, or you get a breakout rash, or you're itchy? Again, difference between officially and unofficially diagnosed, still have to try to tease it out and decide if this patient does need official diagnosis if they have not yet been officially evaluated for atopic history. Atopic also means dermatitis, eczema, psoriasis, all of those things. Okay, so the evaluations. So these are the again, back to evidence-based data and guidelines of what we're supposed to do for people who have dystonia. So I always get a picture of their brain, and I usually add on different parts of their spinal cord depending on their clinical exam. So if they have dystonia that affects head and neck, I make sure I get or head, neck, and arms, I get pictures of the head and neck. If the dystonia is down in the feet, depending on the rest of the physical exam, I will likely get pictures of the spinal cord, because I would like to have all of the pieces of the puzzle rather than kind of doing things piecemeal. I like to have all the pieces of the puzzle on the table so that we know what we're working with. So the MR angio, this is a picture of the blood vessels of the head and or neck, depending on their symptoms. So when patients complain of lightheadedness and dizziness, I usually throw on a picture of this just to make absolutely sure there's no obvious blockage of blood flow to the brain. I also get a picture of the blood vessels of the veins that drain the brain, because when there is an issue with blood vessels that drain the brain, fluid and blood can tend to be more on the backed up side, and that can be a contributing cause of headache. So MR angio as well as venogram. I get a lot of blood tests, so iron deficiency, thyroid abnormalities, vitamin D deficiency, B12 deficiency. All of these things can contribute to worsening of these symptoms and can contribute to tremor. So B12, low levels of B12, we know that patients can have neuropsychiatric symptoms with that. The iron as well. So I have, again, anecdotally observed that iron levels are being more aggressively treated now. So the ferritin is what I test. That's the storage form of iron. And when the levels are in the 30s or lower, I typically place a referral to hematology for evaluation of why is it so low. If it's my young female patients in their 20s and 30s, the most common offending factor is heavy menstrual cycles. If it's my patients in the 60s to 70s age group, common offending factors are chronic gastritis, chronic heartburn, which impairs the gastric mucosa, which reduces the absorption of iron and B12 from the gut into the blood, and or people who chronically take acid reflux medication, which also reduces the absorption of iron and B12 in the stomach. So you have a hard time if you have heartburn, you have a hard time if you're treating your heartburn. And so those are common causes, and I like to evaluate what is the underlying cause there, because low iron levels, I have anecdotally observed, to make people a little bit shaky. Okay, copper, ceruloplasmin, these are usually tested. That's just kind of part of the workup for people who have a movement disorder. It's extremely rare to have an abnormality there. All right, so then the nerve test we talked about. Sometimes we get a nerve test depending on what other clinical symptoms the patients have. If it's something that I think is in the neuromuscular category, I usually get a nerve test to make sure, or check to see if they have a pinched nerve somewhere in the neck or lower back that's contributing to symptoms, again, to have all the pieces of the puzzle. And then I have been sending patients to genetic testing. So dystonia is not a new thing. We know about dystonia. We've known about dystonia for some time. There are known genetic mutations that cause dystonia. So that's a very easy thing to send patients to genetic testing for, because it's already out there. The reason why I strongly do like to send people is because I am looking for whether they have a mutation that it has a known clinical syndrome. For example, if they have mutation X and everyone else with mutation X only has cervical dystonia, then I can say, okay, you're probably just going to have cervical dystonia. If they have mutation Y and everyone else who has mutation Y has head and neck dystonia and hand tremors, but other body parts affected, then I can kind of know for that patient, maybe you're going to have more stuff later on. Maybe we should be more aggressive about evaluations and potential treatment options, anticipating that this might get worse in the future. All right, so then the evaluations for the dysautonomia. So this is a little tricky because the testing here can be falsely normal, basically. So two tests here test for the abnormalities in the automatic nervous system. So number one test is called a tilt table, which sounds just as horrible as it is called. You go in, you lay down on a table, they strap you in, you get flipped up and down in different positions, laying a little bit head elevated, head up totally, depending on how much the patient is able to tolerate. And at any point, if the patient passes out, worst case scenario, or vomits or becomes very, very sick, the test will just be stopped and that will be considered a positive test. But if you're able to tolerate it, your heart rate and blood pressure are measured throughout the test, and it tells us if you had a normal response or an abnormal response. So that's, again, a test for automatic nervous system. The next test is called a QSART. So this means quantitative pseudomotor axon reflex testing. This is a fancy way of testing the small nerve fibers, which are not picked up on that regular nerve test. So the QSART involves a sensor that's basically placed on the skin, and the skin above that sensor is stimulated, and the amount of sweat that comes out of that skin is measured using a special chemical, and it's a microscopic level. So it's not like you can really feel it, but we're looking on a microscopic level how much sweat comes out of that, because sweating is controlled by the automatic nervous system. So again, there should be a normal response and an abnormal response. The abnormal responses can tell us if there's something specifically wrong with the fight or flight portion of the automatic nervous system, or with the rest and digest portion of the automatic nervous system. If one is too high, one is too low, it can actually show us that on that nerve test. So I stick to those two tests because between the two of those, pretty much everyone who I suspect who has dysautonomia, one of these tests at least will be positive. That helps me confirm a diagnosis. I stay away from the skin biopsy as much as I can because it's not always accurate. Number one, it has to be done a very, very specific way by a surgeon who knows how to do it. The the biopsy has to be cut in a very specific way. It has to be inserted into a specific fluid. It has to be refrigerated, this, that. There's a lot of rules. And if every single rule is not done perfectly, it can be a not accurate result. The other part of it not being accurate is if just a patch of skin that hasn't been affected is chosen and that patch of skin just looks normal and then the whole test looks normal. So that's why I kind of stay away from this one, because I usually get everything I need with these first two. But if a patient is like truly interested and they want this, I'm happy to send them for that. I think it's done by dermatologists locally and surgeons. It depends on finding someone who can do it. All right, next part of this is the pain. So again, we talked about pain is subjective. So this is a little tough one to kind of work around. So if the pain seems to be mostly a joint related issue and that patient says I have joint pains out of proportion to what they've really done throughout their lifetime, like they didn't do a heavy physical labor throughout their lifetime, they didn't really beat up their body, but they're hurting a lot. I have a low threshold for referring people to a rheumatologist, and I've anecdotally observed specific genetic panels being tested. So the one that I see commonly is called AVISE CTD, meaning connective tissue disorder. I think there's about 30 little things on there that are tested for to check for things like lupus, Sjogren's syndrome, and a variety of other things. So this is where the question of fibromyalgia comes into play as well. Fibromyalgia is a diagnosis of exclusion, meaning everything else has been checked for and nothing else has shown up on any testing, and the patient still has pain and a specific pattern throughout the body. You meet those criteria, then it's fibromyalgia. So what I'm starting to wonder is if patients actually have small fiber neuropathy that hasn't been diagnosed and or a connective tissue disorder that hasn't been diagnosed, and is that the cause of their fibromyalgia or their pain? So that's something I'm trying to kind of keep an eye on, and hopefully we'll get some information with the genetic testing for this. Okay. So then the evaluation for fatigue. Fatigue, again, super hard thing to put your finger on. Fatigue means metabolic abnormality, poor sleep, anxiety, psychomotor slowing, dysautonomia. So any of these things can contribute to fatigue. So most important is to find out all of the causes of that patient's potential causes of their fatigue. So that's why I do all the other testing. because if it's dysautonomia, that's the causing fatigue, there's a treatment that way. If it's poor sleep, we got to find out what the sleep problem is. Is it because they have iron deficiency? And then, every single thing has to be treated individually for the patient as a whole. So for my patients with fatigue, I always get a sleep test to check for sleep apnea, because untreated sleep apnea increases risk of heart attack, stroke, dementia, but it also is like very, very common cause of fatigue. When you're not sleeping and getting good quality sleep at night, you're tired the rest of the day. And that itself can cause anxiety and depression, which can further worsen fatigue. So for the question of dysautonomia, I send for the tilt table test. For the question of any metabolic abnormalities, I send blood work for that. And I'm sorry, this is an incomplete slide. I also, this is a work in progress presentation. So if I suspect that the patient has a component of psychomotor slowing, I address that in the visit, and we discuss medications that can counteract that, which I will discuss in a few more slides. Okay. Other things that I have been doing as well, if a patient has a strong atopic history, I have a low threshold to send them to an allergist for evaluation of a condition called mast cell activation syndrome. This is basically immune overdrive, and if that is actually diagnosed, there's a specific treatment for that, which I won't get into because it's a little bit outside of my area of specialty. But again, if I have a suspicion that somebody may have this, that's why I send them to an allergist for official testing and treatment, because that could be a contributing factor to fatigue. All right, again, other evaluations now here is where we're in the anecdotal portion. So I have had a low threshold for sending as many patients as possible to genetic testing if they agree to having 4 or 5 of these symptoms that I've discussed, seems to match up to some type of a syndrome that is thus far unofficially, like, no official name for this whole entire condition. So I'm sending people to genetic testing to see if there's an underlying genetic cause or mutation for their dystonia, as well as for small fiber neuropathy, which again, there are known genetic mutations that cause small nerve fibers to operate a little differently for some people with a different threshold that can cause abnormal sensation of pain, either higher or lower thresholds for pain. Again, that's subjective because everyone's perception of pain is different. There are genetic tests to evaluate for connective tissue disorders, so things like Ehlers-Danlos, if they're not able to be diagnosed with a rheumatology visit because a patient doesn't officially meet criteria, then the next step is digging a little deeper with the genetic testing to see if they're in that category. So yeah, that's all. I've been sending people to genetic testing for that, and I don't have many results yet because I just started to do this, so waiting kind of 6 to 12 months probably to get some data back. Okay, so treatments. Now, the treatment for dystonia is counseling and education, of course, educating the patient as to what they have, rehabilitative and supportive care measures, including physical therapy, occupational therapy, speech therapy. There are some oral medications that can be helpful. So levodopa, that is the medication that's used for Parkinson's disease. However, it is helpful for patients who have dystonia in variable degrees of success, depending on what that patient exactly has. Trihexyphenidyl, this is Artane, brand name, again, can reduce rigidity and dystonia. Baclofen and Flexeril, these are basically like muscle relaxers, and sometimes they're helpful. Tetrabenazine is a dopamine blocking medication. It's used for Huntington's disease, but it can be helpful for dystonia as well. Clonazepam is a medication that just kind of reduces central nervous system excitation. It doesn't treat anything specifically. It treats everything generally by sort of bringing everything down a bit. Can be useful for that cervical dystonia, and it can be helpful for the voice tremors that some people have if they have laryngeal dystonia. Botox injections are actually the most effective treatment for cervical dystonia because it basically works by temporarily weakening the muscles that are responsible for contracting and pulling the head from right to left or up and down or whatever direction. It has a very low side effect profile because you don't have to take a pill with this that causes systemic side effects. It's just a localized injection of that medication of botulinum toxin. That's an office procedure that can be useful for the head and neck tremor, a little bit harder for the hand tremor because hands involve multiple muscles and the risk of doing Botox there is that you're going to weaken the hand muscle, so the patient is not even able to use their hand, and that's usually not any better than having a tremor. Neurosurgical intervention, deep brain stimulator therapy surgery is a surgical treatment option for dystonia. It basically involves 2 electrode wires that are inserted down into the brain, connecting to a battery pack in the chest, and those wires provide constant electrical stimulation to 2 portions of the brain that help to reduce dystonia symptoms. This is part of the reason why I send people for genetic testing, because if I'm thinking about deep brain stimulator surgery, I would like to know if they have a genetic form of dystonia that is more suggestive of a localized dystonia for just the head and neck, or is it do they have a mutation that suggests they may suffer from a generalized form of dystonia that can affect the full body. And it helps us guide our management and deciding when we want to do surgical treatment option and what are the reasonable expected outcomes. Integrative medicine is always helpful as well. Things like massage therapy, acupuncture, Reiki, Tai Chi, all of these things are helpful to try to rebalance some of these off-balance mechanisms in the brain. All right, so these are, again, anecdotal observations, things that I have just observed over the past 6 to 12 months, and I'm trying to piece together things. So I have observed that COVID/long COVID is a frequent trigger for these patients. So they may have had something kind of mild up until the point of this, and then they got COVID, or they got the COVID vaccine and everything just like went out of control, just totally snowballed in terms of their immune reactions to things, their sensitivities to medications, sensitivities to other products that they were already using that never were a problem, like lotion or soap. I noticed that in more of my younger patients. In my older age group patients, I've noticed that some hormonal fluctuations may have been a trigger. So it sometimes frequently happens around menopause. So I don't know. Again, I don't know what all of this means yet. I'm just, these are my observations. So I have a suspicion that this is likely something immune mediated, which is part of the reason why I'm sending people to genetic testing and to allergists and to a rheumatologist. There seems to be some type of ethnic prevalence. Most of my patients are Caucasian females. I do have a handful of male patients as well. And when I ask people their ethnic background, I frequently hear Irish, German, Italian. I also frequently hear Eastern European, like Lithuanian or Slovak. And occasionally I hear Native American, and those are the ones that I hear repeatedly. So I suspect there may be an underlying genetic basis of this, which I hope to uncover with the genetic testing. Another anecdotal observation is that patients who have migraines and they have more of the POTS and the dysautonomia, the lightheadedness, dizziness, they have worse days when it's overcast outside, when we're in what is called a low pressure system. So those are the days that are a little worse for them. Days that are a little rainy, cloudy, foggy, their headaches and their dysautonomia symptoms tend to be worse. So I educate patients about that, and I try to tell them to load up with fluids a little extra that day, or even the day before if they know the following day is going to be an overcast day. The other thing I like to make sure is that headaches are not due to the specific condition called IIH, which means idiopathic intracranial hypertension. So this is a condition that is basically high spinal fluid pressure. We don't know what causes it, but sometimes it can look like migraines, and you keep treating that patient for migraines and their headaches never really go away. And that means you should check for this other condition. The way to check for this is an invasive procedure. Unfortunately, it involves a lumbar puncture to check the pressure. I have anecdotally noticed that my patients who are in the dysautonomia profile tend to have headaches, and again, handful of them have ended up having this IIH condition, and that the reason that it needs to be diagnosed is because if it's left untreated for a very long time, the long-term outcome is loss of vision. And if it is diagnosed correctly, there's a very specific medication that is used to help reduce the pressure, which helps to reduce the headaches. And that medicine is called Diamox, which is a diuretic. We don't know the mechanism of how it reduces the spinal fluid pressure, but it does. And then those patients get a little bit of relief of their headaches. In this same category, if somebody has this condition, that's where I make sure to check the blood vessels in the head and neck. making sure that not only are blood vessels supplying good fresh blood, but also that they're draining the used blood out, because if the drainage system is not working properly, that can cause a backup of fluid and pressure, and that can cause headaches as well. So that's where I would order an MR angio as well as an MR venogram or CTA, but I try to avoid radiation in my younger patients, so I usually go for the MRIs instead. Okay, again, more anecdotal observations, not proven, but this is what I've been doing for my patients, and I subjectively feel that people are better depending on how they started. So for the small fiber neuropathy category of patients who have the burning, tingling, little paresthesias, pain, combination of gabapentin, Cymbalta, Lyrica, Zoloft, and amitriptyline. The gabapentin, Cymbalta, and Lyrica they're known nerve pain reducing medications. Amitriptyline also helps reduce nerve discomfort, and it's a little bit more potent for the pain wise. That is also a medication that's used for migraine headaches. The Zoloft is a funny one. This is what I've observed help to reduce the perception of the severity of symptoms in my patients. It helps. I don't know if it gets rid of the pain or it reduces the perception of the pain. I want to say it reduces the perception of the pain. I don't know what makes me say that. That's just what I've kind of gathered over the past 6 to 12 months. It reduces perception of pain. There have been some studies showing like it works on serotonin, which is a neurotransmitter, but there is some idea that maybe it's also works in the dopamine pathways. So for whatever reason, it seems to help my movement disorder patients the best, and helps this whole category of patients as well. For the dysautonomia symptoms, again, depending on what the tilt table and the small fiber neuropathy test show, I use either propranolol or midodrine. So propranolol is a medicine that reduces heart rate, reduces blood pressure. It also somewhat normalizes the heart rate. If people have really high and low heart rates, it sort of seems to bring people into like a normal realm range. Propranolol can be used to help reduce tremor because it penetrates the blood-brain barrier a little bit better, going more into the brain than any of the other beta blockers in its category. And I find that it reduces anxiety a little bit, which indirectly reduces the tremor. So that's where I use that one. The other category is my patients who are lightheaded, dizzy to the point of syncope, which is passing out, or near syncope, where they're so lightheaded and dizzy they really have a hard time functioning. The midodrine boosts up the blood pressure a little bit, and I've noticed that my patients feel a little more energetic with that. Being cautious that it shouldn't be really given after 6 p.m. in the evening because that has a risk of supine hypertension, meaning if you lay down flat, your blood pressure goes too high, and that's dangerous. So you have to use it cautiously, and making sure that the patient has a very close blood pressure monitoring system like that. If I ever have a question and I'm not sure, I don't feel safe, I have a low threshold for referring people to a cardiologist for official cardiac eval of any other things that I may have suspicion for, like cardiac rhythm abnormalities. So that's not a bad idea. My patients who have brain fog, which I suspect is due to cerebral dysautoregulation, maybe. Again, the midodrine seems to help them for whatever reason. For the fatigue, again, depending on what you actually found. If it was a metabolic abnormality, like the low iron, low B12, we fix that. If it's from the dysautonomia, the midodrine, liberalized salt intake, Zoloft, and an LED light seems to help. So liberalized salt intake, I tell patients to aim for 1,000 milligrams of sodium daily. The Zoloft, I aim for 25 or 50 milligrams every morning, making sure to educate patients that this is an activating antidepressant. It gives people energy. So that is the purpose of giving it in the morning, so they have more energy throughout the day. It helps to reduce anxiety a little bit during the day, more so than the other antidepressants in its category. And that helps translate over into easier time falling asleep at night. Frequently, these patients will say they just can't turn their brain off at night. So this helps a little turn their brain off and go to sleep at night and get better sleep at night, which helps everything. The LED light, again, anecdotal. I've been starting to suggest this for patients. Might have something to do with the geographic location in which I practice, which is Pittsburgh. We have mostly overcast weather. We hardly have any sun here, so the winter months are a little bit worse. So I've told people to start looking into the LED lights. When you look on Amazon, it comes up as either 10,000 or 11,000 LUX. I just say go for the 11,000, 20, 30 minutes a day in the morning and then in the evening sometimes too. And I've had some good anecdotal response to that from patients. The psychomotor slowing here, contributing to fatigue, that one is the one that I treat with the Zoloft as an activating antidepressant. Lexapro is also an option, but it tends to increase anxiety a little bit for patients, and it has a common side effect of poor sleep and headaches. So that's kind of what we're trying to treat. So I don't reach for that unless someone is not able to tolerate the Zoloft. All right, then for the headaches, again, combination or any of these, propranolol, verapamil, which is another blood pressure medicine that helps to reduce migraine headaches, and Botox injections. So if somebody qualifies as migraines and we've tried a couple of other medications and they have a hard time tolerating due to side effect because they already have dysautonomia, I kind of quickly move on to the Botox injections because the side effect profile is much lower and it's just better tolerated. Poor sleep. So multiple reasons for this, but poor sleep makes everything worse. So again, Zoloft in the morning, Cymbalta at night has been kind of my go-to little cocktail that seems to do the trick for most people. I do this 30 or 60 milligrams of extended release Cymbalta at bedtime. That tends to help reduce pain as well at night and helps kind of tell the brain it's time to go to sleep. I always get a home sleep test, however, to make sure we're not covering up or missing sleep apnea or any other sleep disorder, really. For patients who fit criteria or are, even if they're close to the POTS criteria, and I suspect that they just didn't not pass the test because that day was just a good day for them, I have a low threshold for trying some midodrine, referring to cardiology, things like support stockings to keep blood and blood pressure higher and higher up in the body. Satiety issues. So some patients will say they either never feel hungry or they're hungry and they eat and eat and eat and they never feel full. Don't know why. Part of the dysautonomia. I've again observed the Zoloft seems to help regulate this. If patients are typically having reduced appetite, and even not in just this category of patients, but other categories of patients as well, the Zoloft I've observed tends to increase appetite and help people feel a little hungry and enjoy their food and then feel satiety at the end of a meal. Pyridostigmine, this is a medication that basically helps muscles work a little stronger and better, but it's not going to give you like Hulk strength or anything. It's on a very small level, and it's more helpful for patients who have a neuromuscular condition like myasthenia gravis. But again, we've started kind of branching out a little bit, trying to use this for patients who have vague difficulty swallowing or vague issues with the GI system, seeing if this helps to normalize things. It gives the rest and digest system a little bit of a push if that is not enough in that patient. GI issues, again, I have a low threshold for referral to GI because there are a lot of GI doctors in around here who have a specialty or interest in dysautonomia, so they can provide some input. If people's gut isn't just not moving enough, the amitriptyline helps the gut move a little bit better. And then if patients are constipated and that's causing pain and reduced satiety, the amitriptyline can help with that. And again, if I try one thing and it doesn't work so good, I have a low threshold for referring to GI because it's a little bit outside of my specialty. Okay, so basically what I wanted to share was that dystonia seems to have some type of a syndrome associated with it, and there's no official like criteria for this or anything. It's something I'm trying to study over the course of my own clinical practice. I'm kind of in the process of gathering data and encouraging as many patients to seek genetic testing so that maybe we can have some answers, because if more causes are found that can help long-term with the treatment of this syndrome of all of these symptoms that seem to go together. However, if you have any specific questions, please discuss with your healthcare provider. If there's anything that you learned in here that you would like to potentially follow up, that would be something you can ask your healthcare provider, whoever it is that's taking care of this for you. That's all. That's all I have.